So first, we have a question directed to Dr. Olson. And the question is, with tools, I usually struggle with what to do once we have identified the domain where the primary struggle is. So, Dr. Olson, could you give us some insight to this?
I'm not sure if I completely understand the question. So tell me it one more time.
With the tools that this person states that they usually struggle with what to do once they've identified the domain. They're having problems identifying the primary struggle.
And I think it's in reference to the different types of assessment tests.
Yeah. When you were talking about different assessment tests, I think the question popped up that what to do after that.
Okay, I'm still not quite fully understanding, but I guess the target symptoms, the most problematic behaviors. A lot of times we end up having to just kind of we may not fully understand what is the underlying cause. If we can, certainly we will try to impact it, but it's not uncommon that we end up, kind of identifying several main target symptoms, and then we try to work out behavioral strategies for that. Dr. Cotton was talking about that, Dr. Mercury as well. Dr. Mercury, I have to ask you about your North Dakota posters.
Yes, yeah. This is in my office, and North Dakota's home for me. So anybody coming into my office sees front and center that I'm from North Dakota.
So I apologize. I must have missed. So where in North Dakota are you from?
Well, I spent most of my time in Grand Forks and in Fargo.
Yeah. Okay. Wonderful.
Okay, we'll move on to our next question. This attendee says, in my experience, I've seen many seniors that have undiagnosed mental health disorders. Is there a way to address their accentuated behaviors without having a diagnosis prior to the dementia diagnosis? And then there's a follow-up question as well. I can wait or let you answer this one first. And it's not, I don't know if it's directed to Dr. Olson alone or to others as well.
Yeah, this was during Dr. Olson's presentation, but it's open to both the presenters.
Yeah, Dr. Mercury, do you want to?
Can you repeat that again? I
Sure. She says, in my experience, I've seen many seniors that have undiagnosed mental health disorders. Is there a way to address their accentuated behaviors without having a diagnosis prior to the dementia diagnosis?
That's a real difficult one. And we do have problems with that. We do have a behavioral neurologist with us who can be helpful, but usually he will defer to one of our two geriatric psychiatrists. So I'm going to give it back to you, Dr. Olson. That's just a tough one.
Yeah, well, and so I guess what I would say is it's legal for us to diagnose psychiatric conditions that had been previously been not officially diagnosed. So we see these folks that have had anxiety all their life, but they've never gone in to see anybody. And then now that I have one just this last week that I saw that turns out he probably had generalized anxiety all of his life, never went in, because you don't do that. And now as the dementia is progressing, this anxiety is just amplified. And so I feel very confident when I talk to the family, the spouse, the children. They say he's always been like this. This has always been a struggle, etc. So I think you can go back and retrospectively say, yes, there really is underlying anxiety plus. And so with this particular person, then I felt more confident to more aggressively treat the anxiety component, as if it, so I just really, so I can push at that, and that in doing that, that did help some of the other behavioral symptoms. And so in the same way as recognizing recurrent episodes of depression that even though they were never treated, in retrospect, that they really were there, so then it will be more likely to push antidepressants or that sort of thing.
Thank you. And this as well for either of you gentlemen, a follow-up question. Are there any studies or anecdotes on seniors with dementia that have unresolved childhood trauma?
I know in our stroke program, we use ACEs, which does look at childhood trauma. I've not used that, and none of us have used that in our dementia clinic. We've only used it in the stroke clinic because it's felt that it predicts a longer time for healing. But Dr. Olson, is there anything you've used?
Yeah, so I guess I don't have a specific reference, but similarly, I have seen a number of patients that now we're trying to help with dementia, and then the fearfulness around bathing. And then we discover that they were sexually abused when they were younger. And then, so how we have to kind of shift just the whole strategy. We're not going to have male caregivers, and we're not going to, childhood trauma definitely can play a part in confounding things. And again, a lot of times you never knew about it, or if people knew about it, they knew about it decades and decades later. So, and probably again accelerates the anxiety, and especially around personal cares.
Okay, thank you, Dr. Olson. One more from this particular attendee who says to ask you, how should we use this mental health research knowledge to impact our work? Overarching, I guess, what are the recommended strategies we should be considering on a state, community, or organizational level?
Awareness and breaking the stigma, and recognizing that treatments, even if they're not as effective as they were when they were younger, that it's still important to try, and that there are factors.
And I think and Dr. Olson, I think you'd agree there again, the challenge is finding someone who is specialized in older adults, because often we'll get someone who is a good psychiatrist, but sees younger adults. And so sometimes, we find that the patient's over-medicated, so it's a challenge.
Dr. Mercury, this is actually a great segue into our next question, which is, what do you recommend for medication adjustments as childhood or adult psychiatric illness goes into older age, in light of course, the pharmacodynamic changes that occur?
So actually, I've got to defer that to Dr. Olson. I'm a psychologist, so I'm a little bit of knowledge is a dangerous thing type person. I don't do medications,
Sure.
So I apologize.
No,
Sorry,
sure, I can help. And so there's several principles, I guess. So number one is, remember when we talked about, that we still want to treat those underlying conditions. We want to be, though, more careful about the meds that we pick. These meds that might have been perfectly fine for 20 or 30-year-olds, this anticholinergic, so that the dry mouth, the dry eyes, those things are much more troublesome. So paroxetine, amitriptyline, oxybate. I mean, there's a series of these meds that we'd steer away as they get older. So number one, shift to more benign medications that have less drug interactions, have better side effect profile, cause less constipation, less orthostasis, those kind of things, because those are the enemies as we get older. Then it's not uncommon that the doses dial back. Not always. I mean, sometimes you have to keep the same doses, um, but it's not uncommon that you can get similar benefit from half the dose or a third of the dose when you become in your 80s and 90s. When I prescribe, I probably drive the pharmacist crazy, but when I prescribe to my 90, 95-year-olds, we break in half or we quarter the tiniest pill made, and we put a little crumb in, and we go slow, and little crumb more and go slow. You just can't blast in with the regular doses.
Also, Dr. Olson, I wanted to emphasize what you said earlier about some of the over-the-counter sleep medications like Tylenol PM, ZzzQuil, Kirkland Sleep Aid. Oh my goodness, with their anticholinergic effects. I mean, it's amazing that those are even allowed to be sold, as far as I'm concerned, because they can cause such problems in older adults.
Diphenhydramine. If you just look for diphenhydramine, it's all over the place, and perfectly okay for 20 and 30-year-olds, terrible for 70, 80, 90, 100-year-olds.
Yeah, and then also some of the urinary incontinence, the old urinary incontinence medications, because they're cheap, so they're still being used. They cross the blood-brain barrier and they're anticholinergic. So sometimes someone comes in, looks like they have a dementia, and our behavioral neurologist cleans up the medications and they do a lot better.
All right, thank you both. This next question falls into the category of maybe type of dysfunctional family relationships. Could you speak to how compassionate care is approached when family members are caring for someone with dementia where maybe there's a history of abuse by the person living with dementia? In those cases, maybe loved one doesn't quite describe how the family caregiver would describe that person.
So are you saying that the patient was abusive
to other family members, and now they're in charge of their care, and still keeping in mind the importance of compassionate care?
I would say it depends on the patient, whether the patient is having behavioral problems or as sometimes people become quote unquote pleasantly demented, and actually you can have a personality change. And so probably getting some psychotherapy for the adult children, because they might still be reacting to the patient because of what happened in the past, even though the patient right now is actually not exhibiting any abusive behavior. So I would say it's complicated in that sense. So definitely treating the caregivers. We're lucky again because we have our social workers, and they can do short-term psychotherapy, which they often do with families, or educating the patients. And then again, I think that's also where, in some cases, a small group environment could be helpful as well.
Thank you, Dr. Mercury. This next question is about the data that was presented on depression with a diagnosis of dementia. So the person asked here, they said, I am wondering if you know how many of the patients in particular had a depression diagnosis before the additional diagnoses of dementia.
I do not recall from the study. I will look it up. And is there a way I could send it to University of North Dakota and it could be shared, or to?
Yes.
Okay. Great.
Yeah.
Thank
So
you.
we will be sending an email later tomorrow with any additional information that needs to be shared. So
Wonderful. Thank you. Because I've got the studies. I just don't recall. Thank you.
thank you.
Okay, for this next question, I'm not quite sure. This is one that, well, we'll just see how it goes. Is there a how-to guide or recommended resource for communities or organizations to implement support groups and or memory cafes? And well, I'll start with that one first.
I don't know if there's a formal guide, but the Alzheimer's Association has excellent resources as to how to have a group. And they can be, you can contact them and get support as to how to do that. Definitely, I would say that's one excellent resource that you can use.
I want to add, I want to promote our GWEPs, the Geriatric Workforce Enhancement Programs. So reach out to your either local Alzheimer's Association chapters or GWEPs, as they're called, because that's what we do, at least in North and South Dakota. If you are and you want to start a memory cafe, reach out to us and we'll figure it out. Our program helped establish a memory cafe in Bismarck, North Dakota, and a memory cafe in Rapid City, South Dakota. So, and
Excellent.
we are always looking for more people to work on these.
Thank you, Gunjan, and you may want to address this one as well, but I will give it to the panel. Are there model programs that communities could implement to increase understanding of dementia, which would help friends, families, and community members be more supportive of the individual and the caregiver, and even potentially serve as a respite provider?
Don't know of any model programs per se. We have some senior centers, and I've been invited. Our behavioral neurologists, our social workers have been invited, and they kind of ask us to talk about aging and staying well, and usually we'll include information about dementia, diet, things like that. But I don't know of a formal one. Dr. Olson, are you aware of any formal?
Boy, I again, like you were saying, the Alzheimer's Association and then the geriatric work there at UND, those are good starts for our region.
I would agree with you, Dr. Olson. Within the Alzheimer's Association, we will discuss that a little bit later in our awareness presentation, but that is really the core of what we do within the Alzheimer's Association, is to increase awareness and to increase those opportunities for people to learn and come together through support groups. We also just identify some resources on our website as well. And there are programs, I know in North Dakota, there are programs for qualified service providers. So if a person is interested in providing care, either for a family member or to become a paid provider, there are opportunities to do that. And definitely can reach out to the Alzheimer's Association for more information on that. We could, at least in each chapter around the country, help you find the way to do that.
The other thing I love about the Alzheimer's Association is your 1-800 number. And a lot of patients are under the misconception that that's like a 911. You should only call it if it's an emergency. And I'm like, no, you can call them in the middle of the night if you need someone to talk to, but they have excellent resources, excellent information. They'll get you in the right direction. So I've used that as a professional. I try to get my patients to use it, but that is just a wonderful resource. And unfortunately, people think it's like for emergencies.
Yeah, exactly. Exactly. There's professionals there, they're master's level social workers that are there to help guide in any area, really, when caring for people living with dementia. Okay, so our next question, I think too, maybe this is directed to the panel, but in seeing all of the presentations today, what are some of the takeaways that you all got from today's information?
So what we as panelists took away?
I think that was the question. I'm not too sure, but
Well,
you know,
I enjoyed the presentations of Dr. Cotton and Dr. Mercury, and I think that I'm excited to hear about the Alzheimer's component of the presentation too. And it just I was very excited about the large number of people that signed up for this. I haven't heard what the actual tally is, but it just shows how much need and how much interest there is. So that was exciting to me. It was that the people would, so many people are interested in taking time out of their day to learn about this.
Dr. Olson, I'd say what I got out of it, I'm not exposed to bipolar disorder and some of the other schizophrenia. We don't get those here. They might go to our downtown hospital, Northwestern Memorial Hospital, but we don't get them out here where I'm at Central DuPage. So learning about that and the associations with dementia and the cognitive problems was very educational for me. We primarily see the depression and the anxiety, and that's primarily what we see. So thank you. I found that very, very helpful.
Thank you both for sharing your thoughts on that. Now, could you comment on approaches to address inappropriate behavior, in particular hypersexuality and disinhibition in FTD?
Yeah, so that's
Mercury, do
definitely.
you want to take on the behavioral aspects? Go ahead.
No, I was going to say part of it is also educating the family member, because I think what they find really distressing is not just the act of what's happening, but the fact that in FTD, the patient can often tell you, yeah, I shouldn't have said that, or I shouldn't be doing that. So intellectually, they know they shouldn't do it, but they're doing it. It's an impulse control disorder. And so letting the family know that, yes, on the one hand, they're making the decision and doing it. On the other hand, though, it's almost like a reflex. When the circumstances are right, they're going to do it. So I think that's part of it, but it's definitely a challenge. And we've seen it with our population with Parkinson's disease. When they start to have dementia, we've had some people with impulse control disorders that have actually been very problematic. We had one who was sexually inappropriate, who actually got arrested, and our movement disorders neurologist had to actually, testify regarding the disease of the Parkinson's dementia as part of what was going on with him. We had another gentleman who could barely get around. I mean, again, Parkinson's, had some beginnings of dementia, barely get around. However, he was able to get a taxi from the Chicago area into Indiana so that he could go and see a prostitute and come back. So it was that strong of a problem, of an urge, that he could not control it. And even though he couldn't take care of his day-to-day things, and we felt he couldn't plan or anything, he sure planned and did that. So it's not just FTD. You can see it in some other disorders. Dr. Olson?
Yeah, and when we really get in a bind, so I mean, you try behavioral, you try with education things, but when it's so out of control, then there's times that we use medication interventions to either reduce sex drive or to reduce testosterone. And these are rare, but SSRIs, have sexual side effects for a number of people. And so that sometimes we use those. And again, if we're much more in a pickle, spironolactone will drop serum testosterone, and once in a while, in extreme situations, Depo-Provera will zero out testosterone. And now that doesn't, there's still general impulsivity when it comes to the frontal temporal, but it really turns off the sexual part of it. So again, this is rare, and I think it should be a psychiatrist that's doing it. But when we're really in a pickle, I've occasionally done those things.
Thank you for your answers to
Obviously,
that.
I'm going to say, this is off-label. This is not FDA approved. These are case reports that are, have been reported having to do with these really difficult situations.
But that's also a problem with the geriatric population, because a lot of the medications end up being, in my opinion, off-label because they call geriatrics a 55-year-old and you're treating someone who's 90. So it's a problem in medicine too.
Yeah, there is.
Well, thank you. Our next question, there's a question on the utility of therapy for mild dementia with depression. And I think maybe the question should be stated, what is the utility of therapy for mild dementia with depression?
So we've had some success, believe it or not, with psychotherapy. And even though, so we had a case, a woman in a nursing home, her daughter moved her from Connecticut and only brought one piece of furniture. So she moved her to the Chicago area, and she was very depressed with that and actually agitated because of that. And the nurses were very concerned about her behavior. And we had myself, first of all, go in, and one of the things I learned about psychotherapy is when you don't know what to do, reflect feelings. So I was a new neuropsychologist at that time, so I reflected feelings. Saw her about a week later. She didn't even recall having met me before, but I did the same thing. And by the third time, the nurses were noticing her behavior had actually modulated a little bit. And I think, and now there's actually research behind that, not research that I've done, but showing that emotional memory is actually stored in a different part of the brain. So a person can have mild dementia, but their emotional memory can still be intact. And so she actually did benefit in the moment, but it actually was beyond just the moment of having her feelings acknowledged and reflected. So psychotherapy is something that can be tried. We ended up then having one of our social workers continue working with her, and it was a sustained change. So I would say psychotherapy is something that can be used. It's not a medication. So like Dr. Olson said, every medication, of course, has a side effect. But we usually start something like that first. Dr. Olson?
I agree with you that in mild dementia, it's definitely worth a try.
Thank you both. Question here about why psychiatrists no longer manage dementia primarily anymore. This person asks, is it because CMS doesn't pay for that?
Well, I guess I am a psychiatrist and I manage dementia behavior and symptoms every day. That's throughout my whole career. Now, but it's true that I'm a geriatric psychiatrist. Now, I'm not sure if they're talking about, maybe the Ariceps or the donepezil and those the memory enhancers. That it's not uncommon that those might be started by neurology, but generally when there's behaviors and troubles, neurology is very happy to move them on to us. And so I would say, and their payment, well, I mean, I guess it's not an important concern. Medicare doesn't reimburse well for anything. And so, my career, I've worked with at a multi-specialty clinic that values my relative value units and not the amount of money that comes in. And so we have no punishment to see patients on Medicare. If you're in private practice, and you have your own business, it's true that you're only going to get about 30% on the dollar. Are there a lot of psychiatrists that aren't comfortable with taking care of geriatrics? I would say probably or possibly. Here in our training program, we have I have actually a 3-month course, an hour a week for 3 months that all of my second and third years psychiatry residents do. And then all of my residents spend a day a week for a year doing psychiatric consultation at area nursing homes. So we have a year of continuity follow-up. And that's the way I learned geriatrics. I learned my geriatrics from an 84-year-old geriatric psychiatrist out in Portland, Oregon, and we went to the place. We went every week, and so I go to nursing homes every week and have for my entire career.
Yeah, and that's my experience. Geriatric psychiatrists will manage dementia. Our behavioral neurologists will take care of dementia. Our geriatricians, the ones who are trained in cognition, will manage dementia. So it just kind of depends, but yeah.
Thank you both. We're going to have one more panel question and then we will get to our next presentation. So this next question, it comes from Nicole and she asks, what is the panel's familiarity with Skills to Care program out of Thomas Jefferson University, which is typically provided by occupational therapists?
I don't know that one.
Yeah, I'm sorry, I'm not familiar either. But certainly occupational therapists and can be very helpful.
Certainly. With this question, I am familiar with Skills to Care. In North Dakota, there are two different service providers. They are private, they do in-home care, and they have their staff trained in Skills to Care, which is a program for occupational therapists that, and I believe physical therapists related to dementia care. And what I understand from the people that provide those services, they do really think that Skills to Care program is beneficial and gives the professionals a lot of insight as to how to care for individuals that are living with dementia. And we do see a lot of people that use their services that agree that their care is really good. So look for those programs in your area, I would say, to learn more.
No, that sounds good. We've got an in-house occupational therapist here, so I'll see if she's familiar with it. It sounds like something we should be doing. So thank you.